Go ahead.
Okay, so thank you for coming. This is going to be our presentation on increasing compliance with patient SCD use. My name's Daisy.
I'm Kathleen.
I'm Dallin.
I'm Jeanette.
I'm Scott.
All right, so for our quality improvement project, first we had to identify a patient problem and then look into what current hospital policies are in place to help mitigate that problem. Our group noticed that there was a lack of patient compliance with SCD use, and we wanted to investigate the factors that contributed to the SCD use non-compliance. So that way we can create a solution in order to help improve those compliance rates. And the significance of this is that VTE prophylaxis compliance is one of the Joint Commission's core measures and is evaluated annually for hospital accreditation. So this is really a big deal for us. And for current practices, according to the Valley Health System policy, mechanical and pharmacological prophylaxis is ordered based off of physician findings on VTE prophylaxis risk assessments. And based on that documentation, the physician will either put an order in or have to document the lack of orders. So something to make note of is that patient refusal is considered a contraindication for mechanical prophylaxis, also known as SCDs. And for the nursing standpoint for documentation, we are required to document an assessment upon initiation and then once per shift thereafter, whereas pharmacological documentation is within the MAR itself.
Okay, so looking at some of the risk factors that do contribute to VTEs in patients, a lot of it can be seen particularly in this type of, on an ortho floor, because patients, are coming back from surgeries, and some of the factors that really increase the chance for having clots are knee surgeries or hip replacements, and then immobility if our patients aren't getting up and walking. It can also be described by Birchhouse triad, which is the stasis of blood flow, so not moving, having a surgery, endothelial injury, which could come from PICC lines or constantly getting IV draws and stuff like that, and then the hypercoagulability state, which depends on the patient, so it could be from sepsis or any other underlying conditions that they might have. So there are just some risk factors to take into account when wanting to initiate, to make sure that the patient does have the SCDs and give them the proper education for it.
So there's a plethora of evidence out there. I just selected 2 systematic reviews that I found just to kind of support our findings. So 2015 systematic review by Abraham and colleagues. They studied a population of 1,079 people. And of the 5 studies that they looked over, I just chose a couple here to be short. In the SCD prophylaxis group, there was a 2.9% incidence rate, whereas in the non-controlled or non-prophylaxis group, there's 8.8. In Fisher and colleagues, there was a 4% in the treatment group and an 11.3 in the no prophylaxis, or those who declined wearing it. Similarly, in the 2016 systematic review by this gentleman, he was able to look at 124 different patients, and I thought these numbers were striking. 57% decrease in DVT risk and 52% decrease in PE risk compared to those who weren't wearing any SCDs. So just kind of the question to set up this is, despite all this evidence out there, why might hospitals see a failure of patients wearing them or not wearing them?
So in our literature review, going through evidence-based practice articles and peer-reviewed journals, we found a 2006 study that was done at Santa Barbara Cottage Hospital that suggests that patient compliance is primarily driven by physicians and nurses. So the article mentions a couple factors to poor compliance, which includes that healthcare professionals may not always appreciate the importance of SCD use, there's no system in place for documentation, and that there's differing unit environments. So things that they suggested in order to resolve these issues is that healthcare professionals might benefit from periodic education and training. And then with the lack of a system in place, they suggested that a professional and formal logging system should be implemented. And then for the differing unit environments, they suggested that SED compliance should be integrated in daily nursing care, despite what unit you're on. And this overall just mentions that compliance should be the best in the most experienced units, and this prospective study suggests these resolutions for these factors. So we're obviously going in the right direction now that we do have documentation requirements according to the Valley Health System policy. But another study that we have found was a 2015 study that was done by obstetrics and gynecology that focused on the importance of patient and nursing education onto SED compliance and the effects of it. So this study showed that with each successive post-operative day, compliance would decrease. And the most common patient stated reason for non-compliance was that the nurse told me I don't need them anymore. So this statement kind of brings us into a focus of, so what is the problem, and is the nurse's competency providing patient education lacking, or what's really the issue here? But in this study, it was noted that 92% of the nurses involved in the study did provide the right educational program, and despite that, there was still a compliance rate of approximately 58%. So something that they did mention in this study was that there was a lack of uniform post-cesarean VTE prophylaxis protocol. So that kind of suggests that we may be needing a national VTE prophylaxis algorithm in order to have everyone on the same page.
Okay, so another study that we did find focused more so on how the nurses were playing a role in this and their education on SED use and how that affected patient compliance. So what they found is that the nurses were lacking some of the education themselves of, taking the steps to letting the patients know why they were on SEDs, and also making sure that even though they were charting that the patient had SEDs, they would take them off for them to ambulate and not necessarily put them back on. So if they're not being put back on, it's not of use to the patients. So the biggest thing that they found from this study is just letting the nurses and the physicians as well know that mechanical prophylaxis is just as important as taking someone's vital signs.
Okay, so a lot of the problems really stem with the patient. Global public awareness of venous thromboembolism. So a global survey highlights a relative lack of public awareness about thrombosis overall, especially DVT and PE. So similarly, there is poor awareness about the signs and symptoms of DVT and PE, the major risk factors for VTE, such as hospitalization, cancer, and the fact that it is actually largely preventable. So patients actually they don't have a ton of medical knowledge, but with heart attacks, things like that, AIDS, they know what those basic symptoms are. With PE and DVT, we found that that really wasn't the case. They didn't really understand the whole process. So therefore, they weren't really careful with those compression devices. Also known was a lack of concern about developing thrombosis in 28% of those surveyed. Global audits reveal a systemic under thromboprophylaxis in patients at moderate and high risk as well. Results show that a lack of education may contribute to that non-compliance. So, next slide, please. This is a little graph they did. So as you can see, you've got, your hypertension, you've got stroke, you've got prostate cancer, things like that. And to the left in red is DVT, PE, thrombosis. And those levels were so much less than the other side. So a lot of this is really educating the patient as to what it is in the first place so that they can understand the severity of it. Okay. So the other thing that we don't often think about is the cost. So this isn't something I originally thought about either at first. Along with the possible development of post-thrombotic syndrome, PTS, cardiovascular and respiratory events, VTE is also shown to prolong those hospital stays. So the cost of those lengthy stays are paramount for the patient as well as the economy. So hospital readmissions are significant concern in the US with active programs, Centers for Medicare, Medicaid Services, Readmissions Reduction Program that required reporting and instituting financial penalties in the case of those readmissions occurring within 30 days. So the nationwide readmission database, notice that over that 1 year in 2013, 14.5% hospital readmission rate was noted within that 30 days. And that ended up costing Medicare $29.6 billion and non-Medicare $21 billion. So simply really educating the staff, like I don't know how much of the staff knew that, I did not. So it's a big hefty number. So when they put it like that, it makes us want to put those compression devices on. Simply educating the staff and patients about the incredible cost of VTE and its related complications can really help to promote inexpensive and non-invasive treatment for that, such as IPC. So here's a little chart of what those cost. So any VTE related readmission, we're looking at 42. Below that, DVT related readmission cost, length of stay, 40,000. So we're all in the 40,000 numbers here, and then down, we're coming a little bit lower in those numbers on the bottom. But it is a hefty price, so it's really important to keep that education going.
Okay, so with mine, I wanted to look into the different alternatives for SCDs. Kind of that picture that I think some patients, and sometimes we as nurses not sure what type we might put on, but that same study that Ibrahim wanted, he actually looked into a comparison between foot and calf differences. And he actually, in his study, he found that foot pumps were more effective than the calf. So you can go to the next one. So the thing I'm thinking about is when safe, if there's a possibility of switching between calf and foot or others, it could really help. In the previous slide, it talked about common symptoms or responses, sorry, that a patient might have from not wearing the SCDs. And I've actually personally heard this in this hospital and in other hospitals. And sometimes it's just because they're too hot. Like they get sweaty under, things like that. And it's not comfortable, especially if you're here for a whole week. That can be kind of annoying to wear that all day long, especially if it's like that. So when safe, and they do have the ability to choose, I think that as nurses, we can help them increase their autonomy. And there's a quote that I wanted to read about autonomy by Ryan and colleagues. It talks about self-determination theory, and it says, autonomous decision-making results in more persistent and consistent behavior, greater satisfaction in decision-making, and overall greater well-being. For those reasons, healthcare personnel and institutions are encouraged to be autonomy supported by enabling patients to exercise their ability to make their own decisions regarding various healthcare options.
So we've already addressed a bunch of points of failure. Some of the less common ones that I think people don't think about are during transfer of care, like moving from one unit to another, and a lack of reassessment on risk factors. Because looking at the Valley Health System policy, every adult patient requires one, but on admission, I don't know if there's any protocol in place to reassess. So I see that as a place that we could improve compliance. Again, preventable risk factors are not optimally managed. So again, it's a change of status of the patient from initial admission. So their risk factors might change, and a risk assessment might need to be either a nurse could initiate, or it could be a physician-ordered one. And then next slide, please. This is just a chart of different points of failures. The next slide, yeah. So methods for improving VTA compliance. The policy already states that adult patients need a risk assessment, so that's being done. Some facilities have chosen to use an opt-out as opposed to like people meeting risk factors and getting VTE therapy. Some places it's the opposite way, where you have to the provider has to opt out of providing them therapy, whether it's mechanical or pharmacological. And One other thing that I was thinking of is we could put in a, how there's a med effect alert in the MAR. We could do something that would initiate training of the patient so they can make an informed decision to refuse. And there's a simple order for it to make things simpler for physicians to decide. And any
Okay.
questions?